The recording. Okay, welcome. So, today is, well, we haven't been together in 3 weeks here, so got a couple of things we want to cover, and then really make sure that everybody's sort of focused on the August 16th e-consent workshop, which is literally just around the corner now. So we'll talk a little bit more about that and how the next couple of weeks we're going to be focusing in on that. But what I'm going to share with you is a couple of the pages for the agenda. I'll show that in a minute. And then we want to talk a little bit about kind of workshop coverage and how we sort of learn from everything that's going on there, because it's really shaping up nicely as an agenda. And then we'll spend half hour, 45 minutes on with Brian and partners talking about the recent Connectathon and look at the demo that they did there. And then at 5, Robbie and colleagues will conduct a bit of a focus group on their efforts to identify how health plans can support collection and sharing of information. So we'll have an ambitious agenda here, as always. So, but before we get started, let me just actually pause for a second and say, we introduce or invite new people. Anyone new on the call here? We just ask people to say hello and where you're from. So if you don't mind.
Yep, I'm happy to introduce myself. Hi, everyone. My name is Gil Duran. I am with Blue Shield of California and a social drivers of health principal, and really interested in the conversation today. Thank you for having me.
You bet.
And I will go ahead and introduce myself as well. So I'm Samadina OJ. I'm also from Blue Shield of California. I work with Gil, and I am in a leadership development program and currently focusing on all of our social determinants of health work. So excited to meet you all and looking forward to this conversation as well.
Cool.
And I'm delighted because my insurance carrier is Blue Shield of California. How's that?
Hi, everyone. My name is Christy Clark. I'm a medical epidemiologist at the CDC Public Health Informatics Office, where I'm the lead advisor on data for health equity, and was connected to you all through my colleague Sanjeev and Nidra. I've been doing a lot of work around housing and homelessness. So I think they had connected with me with y'all around that, but definitely looking forward to learning a lot more about your work. So thank you for having me.
Christy, you should have been on my last call, which was the HL7 Gravity SDOH Public Health Working Group. And there was about 3 or 4 CDC representatives that I think Maria knows as well that are part of that group.
Oh, great. Yeah, no, I also work closely with Maria, but yeah, no, I might try to track down that recording. That sounds great.
Yeah, I'll send it your way.
Thank you.
Christy, there's a number of different intersections between the CDC. Different people have a variety of different relationships with different individuals and different groups within there. Actually, I know Nidra from way back when, like a million years ago, at the very beginning of All In and the stuff we were doing. It's great. It's great that people are sticking with it and connected in lots of ways. So welcome, and feel free to chime in. Anyone else new or?
Yeah, my name is Sal Rana.
Oh, hey, Sal.
We support the Administration of Children and Families, ACF's interoperability initiative. I'm a technical project management over there on the project, and obviously Zane Networks, which we sponsor ODH, which is the Operational Data Hub, was part of the July CMS Connectathon, which Brian Handspicker led with the teams there. So happy to be here as a guest, and I think that went really well, and I'll be here in the background. Thanks.
Cool. Okay. All right, so that's great. Welcome, everybody. Let me try this one more time here. Okay. So I'm going to ask this dumb question. Everybody sees my screen. So the ONC through Tricia Roll has been coordinating the the preparation of this agenda. It's been from my perspective, an iterative process with a lot of people who have been engaged in this work from many different areas, and we've had the good fortune and fun of being able to contribute to it as well. And there's other folks on the call here who have been and will be and continue to be engaged in this work, so it's really kind of cool. And so this is like the second, it might be the third agenda that is iterating. And so I wanted to just put it up there. There's a couple of pages of this, but I wanted to show it to you because the work of, this is all about e-consent, and it's about e-consent mostly from the, again, the medical perspective, and others, sort of join in here, but it's healthcare or medical data into either into other health systems or into outside of medical, but not the flow of data back into healthcare or medicine from the social or education sphere. So it's a good start, and it's considering a lot of the different kinds of data flows and data types. So there's some, as you can see, some upfront work. They're designing really to be mostly interactive and discussion oriented, which is great. I know that they've asked people to register, so you can actually sign up for some of the breakouts, which are going to be limited. So if you haven't registered yet, please do so, and we'll it's on the ONC website there. So, but we have a number of different places where the Project Unify and consent work and related other things, part of the use cases, are going to be shown. And so in the first set of breakouts here, there's 5 areas: birth to end of life. Christine, can I ask you just to say a little bit more about that, just because you've been in the midst of that?
Yeah, so just really quickly, so each of these use cases will focus on a different stage of life. As you can see, the birth and maternal health use case is a neonatal abstinence use case that involves child welfare as the external partner. The childhood use case, I will actually be moderating that session, and that focuses on exchange of data between 2 psychiatrists, one in the private sector, one who works for a school, and the primary care provider for that child. The adolescent use case is about, it's like sports injury, and it's an orthopedics case. I was surprised it didn't cover confidential adolescent services, but that is not in the current use case. And then adulthood is a substance use disorder related case, including some court-ordered treatment. And then the end of life is around post. So, our friends from the now renamed to something I can't remember, PP2PI, are doing both rooms 1 and rooms 3. Like I said, I'm doing room 2. The focus of the discussion is supposed to be on solutions, not on barriers. Any policy issues will be put in a parking lot. So no policy discussion. A technical discussion is, yes, shift, thank you, everybody. So they're asking for a technical solutions discussion, not a policy discussion, to take place during these breakout sessions.
Cool. Do you know, are they publishing the use cases before? Or
yeah, I believe so. They asked Trisha Rolla, who's running this, is on vacation. They asked us to make edits to the use cases by Friday, so they can get corrected early next week. And they weren't 100% sure, but they were definitely considering giving people the use cases ahead of time, and possibly even the discussion questions. But I'm happy to share if anybody's interested, and that doesn't happen.
Okay, great.
Because it's a short time period. So the better prepared people are, it's gonna be a better discussion.
Are there prompting questions, or is just?
Yes. So that's why, again, they were not 100% clear on whether those prompting questions would be shared ahead of time.
Okay,
But again, happy to oblige.
cool. It occurred to me that since they're recording all of these as well, so while it's good to be covered, for various members of Unify to be in these sessions, both supporting and sort of learning, but how we do the synthesis. So if people are in the session, but you can also watch them afterwards. But it's a great start, hopefully. Well, anyways, then there'll be the panel discussion. You guys aren't you debriefing that out loud too?
Yeah, so that is the moderator, that's the panel to follow after the break.
Yeah.
Will be somebody will be reporting back from each one of the 5 sessions. Yes.
Great. Okay. So there'll be some synthesis there. We can think about picking those things up. And so the next session here, it's like half an hour overview of approaches and e-consent. There's 5 areas that are here. As you can see, there's 5. There's actually a 6th one that's on hold. And so Mary Sarah and AWS has one. Mohammed and Medado is there. Hannah, we're here, and Mahin and Tim are here. So this is kind of cool that we actually, because so many people are involved in so many of these initiatives already, that it's kind of like stirring the pot. So it'll be interesting to see how the language we can use can sort of infiltrate across how this actually gets pulled together in terms of a potential utility. And then so that's a quick. There's those 5 sessions happens, and then there's the e-consent scaling. And Jim, I think you're on that as well, right? Have you participated in any of the planning yet for that?
I have not, but I think you're right. I think we confirmed earlier today when you and I talked that I'm on that one. So
Yeah, I don't know. I think Stefan is planning on scheduling what. Yeah, so there'll be like a planning meeting the next week or so, I think, when he gets back.
That's fine. We got plenty of time.
Okay. Well, there's not that much time to talk, so there's not that much stuff to say anyway. So.
Not that much to say, exactly.
Plenty to say, but just not enough time. And then there'll be some reflections on this one. I was actually curious here. This were under the workshop reflections. That's county and federal government leadership reflect. I wonder if they left off state by intentionally or not.
Probably not. There've been a lot of typos in their materials to date. Yeah. But I wanted to point out that this is the wedge. So equity is the place where essentially 2-way information sharing can start to get discussed. Yeah. Because they really, within the scenarios, they really want to talk about sharing from a covered entity out and not be talking about any solutions for sharing into covered entities. But, we talked about the need for hopefully a follow-on workshop or 2. And hopefully that agenda can get set in that final session around health equity.
Yeah.
And Christine, I think this particular session is really of interest on my side. I wish I would be there. Unfortunately, I'll be headed to my daughter's wedding. But, I really see there's a very strong equity issue attached to consent. We know that in the social care world, we tend to have, we're looked at as trusted resources, and we have access to people's very intimate lives by going deep in their homes. So we see that there's probably what should be easier to implement will have some barriers and be harder than it should be, because some of these populations will not want their information shared back to the medical community. So right. I think this,
but they're not even going to touch that, Courtney. So if we right. want to suggest that should happen under the right conditions, that this is the opportunity, to.
Right. So I would put that out there for you all. And certainly it's the, more diverse populations that show up in research time and time again as having more trust issues with healthcare clinicians.
So can I, 2 points. One, Daniel, there's something on your screen. I don't know if it's your Zoom that's kind of blocking the bottom and the side, like the bars.
Yeah.
Anyway, and the other thing I was going to ask is for those who have been involved and have the ear of the people planning, is if they're talking about county and federal there, has there been outreach done for tribal communities are involved in data stuff? Because man, are they left out every left and right.
I think the short answer is no. I'm not aware of tribal organizations or even like ASTO or something like that with connections to tribal being included in the discussion, but that's probably a separate conversation in and of itself.
Well, and what I can tell you, we represent 220 Title VI Native American aging programs for older Americans. And I would say of our universe of social care agencies, those agencies have even less capacity in terms of data standards, technology, and interoperability. So while they probably from an equity lens should be on the bubble, it may be more challenging to them in terms of talking through some of these issues.
Yeah, and I guess the other piece is, this is purely talking about electronic health information.
Mm-hmm.
So that's the focus, not, how do you take something that's not electronic and share it?
Right, but when I'm thinking about like Indian Health Services, for example, like which is,
Yeah, no, it's a good point.
they should be involved in this, especially because there's a whole lot of federal money going into, I don't want to take the topic away, but I don't have the ear of whoever's organizing this. So if somebody else does, it would be good to raise it. There's a ton of money going into HIT improvements in tribal communities, health for Indian Health Services and other stuff. So it's not like they aren't concerned about the issues.
Chris, because I will virtually guarantee they'll be contacted, but whether or not they participate will be one thing. I would ask our two ACF colleagues who are on the call though to reach out to the ANA within ACF, which is actually sort of the social venture part of the Native American community. That would be really ripe to do that because they tend to support more innovative kind of entrepreneurial technology-based kinds of things. And they often have participated in these kind of things in the past. So, but you know what, we have to remember, this is, it's a start, right? We gotta move to the table. We gotta move forward, and this is not one and done. This is the beginning of a very long, torturous march for the next decade. So, someone else will carry the flag further down the road, I suspect. But no, it's great, and I'm sure they'll be receptive to it. Trisha's been great receptive to all that stuff, and I'll talk to Stefan and everybody. Send a note to everybody. Say, where are they at? And
the states.
Participation. What?
And the states.
And the states, yes.
Tribes in the states are missing.
Yes. Well, future's on the wall. Okay. Anyway, so with that, I think we're ready to go into the next section, which I will hand over to Brian and company, and we'll go take away, Brian. I can try to run mine, or I can give you the controls, or we can see what's going on.
You run yours, but let me give a.
Yeah.
Well, but Brian, we've got big black marks all over the screen, so it might be better if you do it.
Is there still one?
Yeah.
How about now?
Better, but not gone.
And there's one on the bottom too.
Yeah.
Well, we might. It's probably good enough we can see now, at least.
Yeah,
that's just weird. Okay. No, it's strange because it's usually when you open your chat on Zoom, the other people don't see it. But I've just opened my chat and I've opened my video so I can see the pictures, and that shows up as a black box. So I need to update my software or something.
Well, let me do a quick intro, and then we will attempt to see if Daniel's version of this will work, or if we have to switch over to mine. Yeah. Frankly, I'm probably going to have the same problem that Daniel does. So let's see how it goes. I'm pretty sure most of us know what the Gravity Project is, but I'm going to do a very brief intro for anybody new who isn't tuned into it. The Gravity Project is an open public collaborative attempting to advance health and social data standardization for health equity. That's their terms, not mine. The goal of Gravity is to build consensus-driven social drivers of health, SDOH data standards for health and social care interoperability, including standards for various terminology or codes for assessment, observations, conditions, interventions of social care services for specific social care domains, such as food insecurity, housing, transportation, et cetera. And also to define a closed loop referral mechanism based on healthcare IT standards called FHIR. You guys all know that. Sorry, I'm reading off of a blog article I'm writing for the Unify blog. Last week we had the Center for Medicare and Medicaid Services brought together a broad range of stakeholders for a virtual CMS FHIR Connectathon. And one of these Connectathon tracks focused on testing the Gravity Project's standards, both codes and the closed loop referral data exchange specification, sometimes referred to as clinical care SDOH-IG or CCI SDOH-IG. They were looking specifically about testing the following three use cases: the ability for the patient assessment of needs using a standard SDOH questionnaire, such as PREPARE or Hunger Vital Signs, the ability for a provider to establish goals associated with a relevant health condition or health concern for a patient, leading to the ability to do a referral to a community-based organization, a service provider. And then in the role of the community-based organization end user, being able to accept, reject, et cetera, that referral, and ultimately to ensure that acceptance was percolated back to the provider so they could know whether or not the intervention was provided. At the Connectathon, we had two teams of vendors testing, or really rather demonstrating, implementation of these use cases, because each of our teams had worked very, very hard in the weeks leading up to the Connectathon test session to make sure that everything was working. And these team names were really an inside joke, but I'll use them anyway because they're helpful. There was the A team, which included Zane Networks, MayJuun, and OCL, supported by the Administration for Children and Families, ACF, and Gold Belt Frontier. And there was the Highlander team, which included Saffron Labs, LMU, Healthix, and MaxMD. I must confess that watching at least the OCL, MayJuun, Zane Networks demo, I literally cried. It was wonderful to see your baby actually working in real life. We have worked so long and hard on this. I can't stress enough what an incredible milestone this Connectathon represents. This was the first time anyone other than an ONC-funded reference implementation brought any Gravity software to a Connectathon. As my understanding, I keep saying this, nobody has corrected me yet, so I'm starting to believe it myself. Whereas often in these Connectathons, the first code brought to a test is kind of test harness code, Postman, to prove that, hey, the spec can be implemented. Look, we could pass this data across this API. We actually had 7 companies bring commercial quality off-the-shelf software to the event with complete user interfaces and functionality. This Connectathon showed not only that the spec could be implemented and could be implemented in an interoperable fashion between the different vendors' products, but more important, that it could be used in real life applications to solve real life problems. It was just amazing. I got to close here before we go into the video. That our own Project Unify work on the SDOH proof of concept demos over the last 2 years really created the foundation for us to be, for at least for OCL, MayJuun, and Zane Networks, to build this first testing of the Gravity SDOH implementation. We were the first people to try the survey question and answer codes, the observation codes, the condition codes that we were defining in the terminology, the community working group. And we were apparently also the first to test out using the FHIR clinical care SDOH-IG to exchange information. So we have to pat ourselves on the back because these proof of concept demos really positioned the, if you will, the Project Unify alumni team of MayJuun, Zane, and Open City Labs, as well as ACF and Goldbelt, to work together to deliver an end-to-end closed loop referral using commercial off-the-shelf software based on these standards. Really, it is, you will see, I hope, that it was just an amazing demonstration. And we also, by the way, succeeded in demonstrating FAST's Smart on Fire launch, something called UDAP, which is the ability to register a piece of software with an existing FHIR server, and National Directory. So with that said, probably far too much said,
Great, Brian.
Daniel, play away.
I just gave you the virtual clapping. You really, and the bunch of people for the last 2 years have really put their shoulder to the proverbial flywheel. And this is yet another sort of more mature example of what collaborative effort can actually do. Imagine what would happen if there was significant funding behind it. Watch out, you actually get something done. So watch out, it's gonna happen. So thanks, Brian, for doing that and really just marshaling the troops, so to speak. That's not a good term, but encouraging people to sort of participate.
And in all fairness, I should point out that I'm only demoing the stuff that our unified team did. There's another team there if you want. I'm going to put into the chat the link to the full 3.5 hours. And I do recommend taking a look at what Saffron Labs and company did for their demo. It's a different take on it, but the fact that they also were able to use the same standards to do this just says that we did a pretty darn good job in defining the standards to begin with.
That's really excellent. So Shelley, you said, is this the same link to the demo or is this something different?
Yeah, it's the same thing. Yeah, that Brian's referring to.
Oh, great. Good.
Yeah, great job, Brian. I enjoyed it too, as well. I was more of an observer in this project, but it was great to see the technical collaborations that came, that were in place, and the people that came together to make this happen. I thought it was a really good demonstration.
I'm doing a quick scan through this, and I don't see a link to the recording. Is there a link to the recording on what you put in the chat, Shelley?
Well, I'll just go to what you already gave me, and then we can take it from there.
Yeah,
Brian?
you go there. I'm going to put the link in the chat for the recording.
So we'll play 15 minutes of this, and then we'll start up at 5 with Robbie. So we got to find hopefully this will work.
Hey, Brian, question for you on the demonstration. We've been seeing from the HIE seat a lot of
Mary, forgive me, but could you hold that question for the end? Because we have a 25-minute recording that we're now only going to have 15 minutes for.
Okay.
Is this it, Brian?
Yeah.
5922?
Pardon?
Do you see my screen?
Yes.
Okay. So I think we're 5937. There we go.
Now you want to go to 5930.
Well,
close enough. Close enough.
Close enough for you.
I'll mess with it.
I should start that. Screen 1. Share.
And Daniel, I think that if you do
see a slide that says the gravity SDOH exchange demonstrations.
So just want to confirm everyone can hear that on their computer.
It's a little soft.
Yes.
Okay.
If everybody will mute, it will help.
Yeah, good point.
And if you can crank it up.
I'll crank it up more if I can.
And also go full screen, hit the little
Great.
square in the
I think we're
corner.
at time. We can get started. So again, very grateful for everyone, especially the folks that are going to be demonstrating today the use of the implementation guide. There's a lot of, I hope very demonstrable information that we'll be sharing, and you'll actually see the IG in context. We've created personas and we talk about the specific use cases and their actors. We've actually gotten a large crowd together today. Introduce myself very quickly. Aaron Seib. I'm with Saffron Labs. I am also part of the executive committee at Gravity and have been hopefully helping facilitate the demonstrations you're about to see today. Before we get started, I just want to kind of echo and thank all of the contributors that have led up to this day. So we have had a large number of participants in the IG drafting long before today. I think we gave a shout out to the AMA earlier. I would also indicate, EMI advisors being very early stage authors, contributors to the IG, as well as MaxMD and Enable Care. Lloyd McKenzie, fire god that he is also one of the early participants. I need to turn on my video. Sorry, guys. Give me one sec.
Brian, should I move this forward or leave it?
I would move it forward. We might, Brian, if we're short on time, we might want to skip the overview of all the resources, your intro, since you already did an intro.
He's almost done.
Said earlier today,
we're spending more time arguing about it than letting him finish.
Two separate sessions. Both of these groups worked independently using the standards and enabled interoperability across their product suites. That's an important milestone to be able to demonstrate that, showing the use of the IG standards from the perspective of different vendors and validating that the standards and the interpretation of standards enabled interoperability for the use cases that we're about to share. Our hope is that tomorrow, later this afternoon and tomorrow, we do further interoperability testing with others from the community and amongst these participants in these two sessions. I think that the first session is really featuring 3 vendors and a number of other participants, including MayJuun, folks from Zane Networks, Frontier, the Global folks, ACF, as well as Open City Labs.
Keep it on this slide if I'm supposed to go next.
You're up, my friend.
Great. I'm Brian. Thank you, Aaron. I'm Brian Hanspicker. I'm Chief Technology Officer for Open City Labs. I'm also on the Gravity Technical Advisory Committee, as well as HL7's Human and Social Services Working Group and Direct Trust's Information Exchange for Human Services. This session will show interoperability testing between MayJuun, Zane Networks, and Open City Labs. And we're joined and supported by the Administration for Children and Families and Gold Belt Frontier. On some of the user interfaces, you'll note the acronym INCK, I-N-C-K, which stands for CMMI's Integrated Care for Kids program, which for this test session is being repurposed for a user story involving an older American, demonstrating that social drivers of health know no age boundaries. Next slide. So consider this an example of integrated care for older Americans, in which we've got a 71-year-old, I think now. He had a birthday yesterday, I think. Mark Daniels is a patient with diabetes type 2 and coronary artery disease. We've got if you're a gamer, we've got a non-player character, Dr. Peyton, who doesn't actually participate directly in this testing session, but he needs to be there in order to give to ask care coordinator Michelle Zancan to create a task for Mr. Daniels to take a prepare survey on his smartphone. That in turn will enable Michelle to ask referral coordinator Matt Bishop to search for needed services in the national directory and create referrals to a service. Reza Shah is a case manager who will receive that referral for home delivered meals and provide the service, close the service request by setting the status on the referral to complete, and actually close the task and by setting the status on the referral to complete. And then Michelle will be able to recheck in ODH that the task and service request have been completed. Next slide. So involved in this scenario are, as the patient coordination system, Zane Network's operational data hub. The patient survey app is MayJuun's Questionario. The referral management solution is coming from Open City Labs Navigator 360. And the CBO directory is going to be the national directory. I don't think we're demoing the 211 aspect of it. Next slide. As part of this, we are covering all 4 of the Gravity use cases: assessment, referral initiation, closed loop referral, and of course, provider reviews of that closed loop referral. And it is going to involve FHIR resources of task, patient, questionnaire response, observation and condition, health concern, for food insecurity, the Gravity codes, the practitioner, the task, service request, patient record, care plan, goals. You get the idea. Every single one of those bold items we are going to be touching upon as part of the interoperability between our various products. And with that, we're going to skip the rest of the slides. When you get to slides later on, feel free to read the final 3 slides and turn this over to Michelle to start the demo, since an image is worth 1,000 words.
Thank you, Brian. So
Thank
I'm
you,
going to
Michelle.
go ahead and share my screen.
And my apologies, Michelle, I should have introduced you. This is Michelle Zancan from Zane Networks.
Hi, thank you, Brian.
Welcome, Michelle. Thank you.
Here we're going to start our demonstration in the Operational Data Hub, which we fondly refer to as ODH. In this demonstration, the care coordinator has been asked by Dr. Payton to have her patient, Mark Daniels, complete the PREPARE questionnaire. So I've logged into my care management system, and a quick review of the dashboard just to kind of orient you. We have ability in this platform to have a Tableau link so that you can pull data straight from your Tableau. We can also do data studios in here. There's a complete client list that's searchable and filterable. And then at the bottom is a comprehensive list of tasks or interventions that I have to, as this care manager, care coordinator, that I have to perform. So I don't have to open every single record to see what my work is. My work populates automatically here for me. So in this demonstration, we are going to go into our patient, our person, Mark Daniels. We have our, our healthcare double check, make sure we're in the right record. And then this opens us up here into the individual person's actual record. All the information on this screen is specific to this person here. The top, you've got your demographics. Here we have you've got your care planning section here. We also have the ability as a smart on to launch Smart on FHIR applications here, which makes this modular. Down here at the bottom, we've got our client care team. The care team is where you can build out the professionals who are working with this client, related persons, where you can add in the family members who participate in the care, and then documentation of all communication, as well as documentation of the client's insurance and benefits. Across here, we've got our task, our interventions. This is where the tasks and interventions, the work that needs to be done for this person happens. There's the ability to have PDF, HTML documents can be saved and viewed by the care team here within the attachments. This is pulled from the database. In your observations tab, it holds observation resources, for example, calculated scores, lab values, and vital signs. And then conditions is populated from the condition health concern resources. Examples of this is problems and potential diagnoses. So moving on with the demonstration here in our care team task, I'm going to create a new task by opening up my field, complete self-assessment. This is an accepted task. It's routine. It's part of our plan. And all of our drop downs in here are FHIR compliant. And I'm going to assign this to myself because I'll have to follow up if I don't see this completed by the patient. I'm going to give this person a week to get this done. And then put here, follow up with mark if not complete. Okay, well, and save. I get a success message here at the bottom. It says that my task resource has been updated. And then here, if I open up my screen to expand so you can see better, you can see this self-assessment task right here. This is the one I just created. It's upcoming and it's marked for me to see that it needs to be done. Also, if I come back here to my dashboard, then that same task that I just created shows up here. So this is my comprehensive list of what I have to do. So it shows up here and I know my due date is the 27th. Now I'll be turning over to Dr. Falconberry, who is acting as Mr. Daniels.
Thanks, Michelle. So let me make sure I share my screen. And all right, so as you can see in my email, I now have a new email with an invitation to complete the ACL link. So we go in and we see that there's a link that I can click on, which should open up the questionnaire. This will ask me for authentication. We have implemented multiple types of authentication for this because we're using the Google Healthcare API on the back end. We can just log in using our normal Google account, but we can also do a smart launch. We've done one-time passwords. So again, trying to be flexible, especially with clients out in the community, we know that we have to be able to work with multiple servers, multiple functions, and allow them multiple ways to get the data. So go ahead and I log in. And this is primarily used on a mobile application. And so it looks a little bit better when it's slightly smaller, which is why I'm not using the whole screen. And the first thing, and one of the nice things about Prepare is we know it has multiple languages. And we purposely built in for our app to be able to support multiple languages. Now Prepare has 26, so I won't demonstrate all 26 of those. Oh, that didn't change that. So with our application, it will dynamically render any questionnaire that's in FHIR. And so Prepare is nice because it's obviously a standard questionnaire that we can go through and complete. But
I'm sorry, I missed that. What was the name of the tool that will display any questionnaire that you're using?
Sorry, it's our tool. It's called Questionario. It's a application written in a language called Flutter, so it can run on iOS, Android, web, but also now natively on Linux, Mac, and Windows.
Is it like open source publicly available or it's yours?
It's ours.
Oh, oh well, thanks.
The underlying standards that Gray is using and others will be using in this demonstration are open standards. And they're published by Gravity in some cases and by the folks that are actually the authors of them in others.
And again, Prepare is nice because it is readily available and out there. We also have a tool for creating new questionnaires with a simple spreadsheet. If you need to create specific questionnaires that are not standard, that have not already been written into FHIR, that will automatically create new FHIR questionnaires that you can then put anywhere you want, including our application.
A couple questions in the chat. One is, are all of the questions in the survey instrument encoded with link codes?
Yes, in this case there are, because again, prepare is a standardized questionnaire. If you create your own, it can be or not, depending on how you label it. We've certainly done that in some cases, and then some are, because they're very specific to the individual case, then it may not have a LOINC code unless we specifically author it.
Thanks, Greg.
And
And if
so
you can zoom in ever so slightly, that would be great too. Thank you.
let's see on. Is that any better?
Yes.
All right. So now I think I messed up my window. So again, this allows you to finish questionnaires. You can assign multiple questionnaires instead of just a single one. We've done screening for the Inc. teams where we have, I think, 40 questionnaires over 10 different age groups. And so you can complete multiple at the same time. And then when you're ready, we just go ahead and submit. And we submit, and it lets us know that it's successfully completed. And what this has done is it's created a new questionnaire response, one for each questionnaire. It has, in this case, created a new condition for food insecurity. I should have pointed it out, but I mentioned that I was worried about obtaining food. And in some cases, it will also create scores. We can create a report where we score the results of the individual questions and produce a score, whether it's for a PHQ-9 or for, again, anything else you want. And this is all built into FHIR using FHIR path, so none of the underlying code has to change. And it is also changed task to completed. And so with any luck, now that I have submitted it, I should have gotten an email saying I completed it. And so Michelle should have as well, which means that the ODH should have alerted that we completed the assessment.
Yes, I am waiting on my email. My computer is being very slow today. There it is. All right, go ahead and share my screen. Yep. So here I'm within, can you all see my screen?
Yes, we can.
Okay, so here's I've gotten my email to let me know that that this patient with this ID has finished the self-assessment tool. And this is a link, so it takes me so I can go straight into my dashboard. And it's gonna take me directly into this person's record. So here, if we take a look at the tasks, you see that self-assessment task is missing. This task list only keeps open tasks visible by default, but I can hit the complete if I want the completed tasks to be included. So when we do that, we've tested this a couple times. You can see here that we've got this completed task right here. This is all right. And then now that I know I've got a completed task, I'm going to jump over here into my conditions. You can see here, we've got this food insecurity condition that was added. This is a new one. Again, we've been testing. This is a new one that was added today based on the assessment that was just done. So this alerts me that I need to do something now. I've got to act on this food insecurity. So that brings us up here to our care planning section. We've got multiple pathways right now. We're using 3. We're building 2 additional out now, and these pathways are specific and customizable. If I open up the social services pathway, I can add a goal. We have specific goals that were defined, addressing food insecurity. This is immediate. I want to address this very quickly. This is proposed, it's in progress. And I'm going to assign this to my, over to my referral coordinator and hit save. Again, I'll get my success message here. If you come here, you can see, here's my new goal here. The goals are tied to the FHIR plan definition. So that means that they're customizable and we can do automated workflows. The automation can include sub goals, it can include tasks or interventions, and it can include resources. So in this goal, we have included an automated referral task that populates here under the goal, so you can see what's happening here. But then also, if you open up the task section, it's gonna, these are by date due. Where's my referral task? Oh, it's a goal task. I've got my referral task here. So with that, then we pass it over to Matt, who is acting as the referral
Great.
coordinator.
Thanks, Michelle. So here you can see my email. I've received a task. I'm just going to click on that task. It's going to prompt me. I've already logged in, so it is going to just automatically bring up the record associated with that particular patient. And we're going to use OpenSea Labs Navigator 360. So I'm going to demonstrate the Smart on FHIR launch. This is a Smart on FHIR launch where we're passing patient contextual data into Navigator 360 from ODH. What you're going to see is our FHIR directory, where we have data coming in from, we're basically essentially a network of networks. So we have the NJ211 directory, the statewide information referral service funded by United Way. We have the national directory and OpenSea Labs own directory. And part of the goal of this approach is to meet organizations where they are and meet systems where they are in terms of supporting a wide variety of standards of what those standards support. And by reaching organizations in their system of record, we can improve care coordination. So we're going to search for, within the national directory, for home delivered meals, because we have a patient with food insecurity. So here we have the Nutrition Sites program. We want to screen for eligibility for this program. So it's going to ask me a series of questions. We selected a program that has a very simple eligibility process, but we have an extensive, complex process of being able to determine very complex eligibility requirements. And we are going to see if this patient is eligible for this service. And by selecting show eligible services only, we know that it looks like we are eligible. Mark Daniels, our patient, is eligible for this. So we're going to go ahead and click refer. So we're going to just fill out some information about this. It's urgent because the patient is food insecure. And we're pulling in the goal of obtaining food security that you saw in ODH, and we're pulling in the codes associated with the reason for the referral. We can add free text information here or decide whether we want to share the referral information with the patient directly. But we're just going to go ahead and collect consent from the patient to share their information. And you can see we've made the referral on from my side here. So now we're gonna see from the perspective of Reza Shah, who is the organization that is now receiving the referral. So they've received an email indicating that they've received a referral and they can log into OpenSea Labs to view it. So Reza Shah is logging in. We have a referral from Carla Sanchez. And we're going to update the status of this referral. we're going to accept it. And let's go ahead and add some procedures. We could enter the code if we know that. Let's evaluate the patient for eligibility for the program. Let's educate. Deliver meals. And let's provide. And then finally, let's change the status of the referral to completed. Great. So now I'm going to log in. I'm going to log out with Reza Shah and log back in so that you can see that the other user here has received updated information about this referral. See, so here we have the updated status of the referral and the procedures that have been provided. Now I think I'm handing it back now to Michelle to take us back to ODH. Is that right, Michelle?
I think
we're wrapping. Okay.
Yep, I think we're done.
Perfect. Wow, that looks great, guys.
I think we're done now. Yes.
So, Brian, is there more commentary afterwards, or does it just move on to the next? If people want to get more.
There's a little more commentary. Aaron Sieb says very complimentary things about, he represents a worthy competition, by the way. Said very complimentary things about us. But I think we can move on to Robbie now at this point.
That's great. So we'll, are we able to post this? I guess it's public, right? It's on the component site.
Yeah, and I'm writing that blog article for.
Okay.
And we'll include a link to the video in that blog article.
No, that's great, and hats off to you on actually pulling all those things together. Amazing, there. Great to see it.
It is the direct consequence of 3 different proof of concepts that we did over the last. So.
Yeah, that's what
unify.
That's what's incredible, is that just you can see the growth of it, and as we move into EI and housing, it's gonna just slide right in there. So with that segue, we are wanting to provide some time for Robbie and his team to interrogate the group a bit. No, just actually have some discussion with the group about some really important topics. So I encourage you to stay on. This should be fascinating, and part of it is also, just to put a 10-second plug in here, is as we're going into the the work at the ONC and the workshop, I'm really interested in bringing sort of California and New York and Minnesota and Colorado and those groups together, because this is really a significant initiative, and it is a big deal, and it could potentially be a seismic change that happens. So it's connected in terms of trying to connect East Coast and West Coast and everything in between there. So Robbie, I turn over the screen to you, and go for it. If folks can stay on as long as they can, great. Let's go.
Awesome. Well, thank you, Daniel. And as was mentioned earlier, feel free to, grab the beverage of your choice. We'd love to make this conversational. But I've been tuning into lots of these meetings, but for those of you who might not know me, I'm Robbie Franceschini. I work with Blue Path Health. Primarily, I've been coming to these meetings, to learn about all of your work, really on behalf of a coalition I helped to manage in California, Connecting for Better Health, really focused on, advancing data sharing policy in this state. I think initially and primarily on health, and I think that's, led us to social care, especially as the state has been focused on that work. My colleague Karen and I are here today on a separate but related project that I can, dig into in a little more detail in just a moment. But Karen, I'll let you introduce yourself first.
Hi, everyone. I'm Karen Shore. Been working with Robbie and the folks at Blue Path Health on a variety of projects. And we are working on a white paper on social determinants of health and social needs and kind of what particular contribution health plans can make in that space. So nice to meet everybody and look forward to the conversation.
Excellent. Yeah, and I guess just for background, so Karen and I are working on this project with Blue Shield of California's Industry Initiatives team in collaboration with Gil, I know who's on the call, and his team in the community health department, and really focused on, as Karen said, how health plans can support social needs and SDOH work, particularly around data capture, sharing, and use. I think many of you obviously are familiar with Gravity project, and Blue Shield has been involved in efforts to help providers with workflow and technical assistance be able to capture Z codes. There's been work around referral management around the state too. And then also I think another driver is really around Medicaid transformation, and with our latest 1115 waiver, CalAIM, which really seeks to address social needs for certain populations within our state's Medicaid program. So really, I think in that context, care plans and referrals and billing and the like come up. But I think we're really interested in speaking with you all, and happy to meet separately too if we run out of time today with many of you in terms of really, I think, understanding some of the needs of your particular organizations and constituencies, and then what is healthcare, or specifically health plans' role in helping address a lot of this work. And I guess just for context too, we know there are a lot of frameworks and definitions out there, but we're focused on both, I think, social needs and social determinants. So social determinants, we've been using the WHO definition around the conditions in which people are born, live, work, play. And then also too around social needs. So, the needs of individuals like safe and affordable housing, access to healthy foods that may result from social determinants. Any questions before we jump into specific questions at all?
Could you say something about what's being done so far by health plans, just so that we have context? I mean, I can respond on what we're seeing in other states that aren't California, but.
Yeah, so from my perspective, especially in California, I think it's all over the board, to be honest and quite frank, right? So I think I think like with healthcare foundations and providers and hospitals, I think health plans are being asked to start addressing health-related social needs and social determinants, and are doing that, I think, to varying degrees and in different capacities. So I think the examples we provided before are some of the main ones, right? I think on a focus on like coding and referral management. But I think, other ideas that I think have come to mind in conversation with some of you in different forums, how can we kind of right size health plans' roles in this work to support and maybe not lead? What are needs when it comes to sharing other types of data, supporting IT or human resources that, social care organizations might have too. But, I think we'd love to hear from you all how health plans can support you in your work. And maybe it would be helpful, I guess, to start first, with the question, and I'll kind of modify the ones we shared. What maybe are some of your constituents or organizations or members, goals or activities when it comes to capturing or sharing or using data, and maybe some of the challenges, that you're facing, just so we can kind of get a baseline understanding of some of the needs.
So Robbie, I'll jump in. I put it in the chat. It looks like Gil has responded to my question, but essentially working closely with providers, not necessarily in the state of California, but in other states. I hear concerns being expressed that to operationalize work associated with this, even though it maybe have been built into the fabric of behavioral health services and case management forever, when you start talking about interoperability and data exchange, there's costs that providers incur associated with things they need to do at their EHR level. And so Karen's shaking her head. So my question really was simply in the sphere of influence that you all are trying to have in the state of California, what are you seeing and or momentum around this? I can see that somebody has responded about a partnership, but again, I'm looking for you to comment to cost sharing for these things to become actualized.
Sure, and I know Gil put in the chat the partnership that Blue Shield has with our state's primary care association to, you know, help FQs work with their vendors to be able to identify social needs, you know, in the workflow and within the EHR. I think one of the challenges our state faces is it's hard to do one thing across the state. And so often that gets delegated down to manage care plans or to counties. So, you know, I think what we'd love to do is like really highlight what, you know, stakeholders think some of the needs are and be able to raise those up to influence Blue Shield's policy agenda and advocacy agenda, as well as those of other health plans, and really, you know, bring to the fore, you know, some actionable things that, you know, health plans can do to help, you know, address those needs, whether it's, you know, dollars towards technical assistance or, you know, vendor procurement, you know, integrations, whatever the need may be.
So again, the suggestion would be is that, you know, whether the so if the providers are capitated, raise their rates, you know, if they're at a risk. If there's still payments for fee for service, then those reimbursement codes should be reconsidered in terms of, you know, whatever codes they would want people to be using for actually performing those functions, to build in the cost for infrastructure. And maybe it's just for a short period of time. So maybe for the next 3 years or 5 years or whatever, you know, that there's a rate increase at the plan level. If the plan is really, if you're going to the plans because their pockets are deeper, ask them to reimburse the codes at a higher rate in order to do this.
Do you think another related strategy is, you know, bake it into value-based payment models or into the capitated model itself versus kind of maybe a hybrid, you know, with a fee for service? Or
many providers aren't equipped to really deal with capitation. It's a very complex thing, especially with all the other things you're doing in California. Christine is mentioning some other commentary to what I'm saying. So I think at this point, I'm going to stop talking. I think I've made the point, and in terms of the solution, maybe others would want to chime in. And again, we've only got about 8 more minutes to this.
Right. Robbie, Courtney Baldridge from US Aging. Hi, good to see you.
Courtney.
You know, can't say enough about funding. It is a critical issue, and it is something that needs to be addressed. We see that different plans are taking different approaches. You know, they're oftentimes willing to fund their own lives and, you know, capitated rates or value-based rates. But I think one of the unique challenges inside of a CIE or a HIN or a hub or a SHARP is I think you will see pushback from our network and other CBOs in terms of there being rate setting done by third parties that don't understand and can reflect the actual cost involved for these entities. And I know this has been an issue that we've seen repeatedly, and it really addresses a lot of sensitivities. The other thing I think you will see across MCOs, and again, the MCOs are taking very different pathways on this in talking to them on a regular basis. Typically, the MCOs want the CBOs and our network folks to input into their portals. You know, they don't, there are some that may be using a SHARP, but that's a whole different ball game. You've got with the MCOs, the lives that they're managing that they want to communicate about, where they're having agencies and CBOs input directly into their portals. We have agencies that input into 12 to 15 portals. I mean, it's crazy.
Yeah.
And then you also have the lives that the MCOs are encouraging to use a sharp that may be sitting on their website. The other really kind of demarcation point on all of that is what is the appropriate use of technology to manage certain populations. I would suggest that most of us on this call could probably go into a sharp or get on Google and figure out what we need and find a phone number or a website and launch our own search and engagement. When you're talking at-risk and complex patients, it's a whole different ball game. So I think, you know, that's another thing to understand. And I think some of the MCOs have not yet figured out where is their best use of technology versus partnerships on the ground with folks. So I think that's a critical thing to look at. And the one last thing I will leave, since you know you're immersed in the CIE effort, is what type of data are you going to be able to pull down? And I think this is something we're becoming increasingly concerned about, that as all of us are sitting here working on advancing a digital health landscape here, what is high quality data? Because at the end of the day, if the entire system is relying on a 12-question automated prepare assessment as our baseline for data, that doesn't begin to reflect what goes on the ground with high-risk, complex patients. And what I will tell you at that point, you're capturing maybe 20% of the story. When you walk into someone's home, it is a whole different ball game. So I put it in the category, not to offend anyone, of garbage in, garbage out. Are you looking for full data that really tells the story and allows us to care for these patients? Or are you just looking to move data, any kind of data at all? So I think those are some decision points that MCOs and other stakeholders in the system need to really be thoughtful about. But all of that is condition on top of the condition that funding comes for these social care organizations, both to provide the services and to improve their technology and interoperability infrastructure.
No, that's helpful. Thank you, Courtney.
Anytime. Feel free to reach out offline if you want. You know where to find me.
Definitely. Any other thoughts on, you know, particular needs?
So at OpenSea Labs, we've heard from various community-based organizations, all the things that Courtney has said. You know, there's one medically tailored meals organization in New York City, and I think they're using like 4 or 5 sharps, right? Because each managed care organization or hospital system uses a different tool, and they just require them to use that tool. So if there's ways that the state or that your agency can require standards-based data exchange or put that into procurement, you know, in the same spirit of the 21st Century Cures Act, you know, no information blocking, you need to be able to make these standards-based referrals. Then organizations can choose the software that they want, right? And there isn't always a one size fits all, and there you don't have people switching systems. Yeah, I can't emphasize that enough. That the needs of a AAA are different from the needs of a homeless management information system, which are different from the food pantry. And so the idea that you are going to just have one tool and say everybody has to use this one thing, doesn't seem to make a whole lot of sense.
Matt, thank you for saying that. I think that's critically important. And I know specifically with our network, we're very different than a lot of other social care entities in that we were congressionally mandated. The creation of AAAs were congressionally mandated as part of the Older Americans Act. We have a nationwide standardized footprint, and we essentially are our own hub. So what type of entity should there be an entity that sits between a AAA and a payer really comes into question, where a loosely organized group of CBOs or a mom and pop CBO absolutely can benefit from having a structure they plug into. So to Matt's point, folks are going to be at different entrance ramps with different capacities along the way. And I think one of the, really big pieces is how do they engage with the agencies? How do they connect into the agencies? For our network, there are systems that are mandated that they use in the states. The AAAs don't get to make those decisions. The states do. The states get to decide those data sets. So our agencies start with a legacy system that then they're building on top of. And 50% of our agencies do contract with MCOs or health systems. It's how does that work fit in? And right now, unfortunately, it means they're logging into different portals. So it doesn't fit too well, but the agencies are making it work.
No, that's really helpful. And it sounds like, I guess I want to capture what you said just now. Like it almost sounds like in terms of plugging in, Courtney, like, is it helpful to use the metaphor of like an MSO with medical groups and IPAs, where, the MSO, the Management Services Organization, helps those, independent docs or medical groups, plug in and have, billing, sometimes EHR, et cetera, taken care of, right? Deal with the administration, ideally interoperability as well, and hold that relationship with the health plan or the MCO.
Well, Robbie, it's interesting you mentioned that. We have entities that are called network lead entities, that they serve as kind of the lead contracting unit, maybe in a region or in a state. But one of the other very interesting things is there's 620 area agencies on aging responsible for every street corner in the country, 220 Title VI Native American aging programs for native lands. They contract over 20,000 local aging service providers. So when I say they're a massive network, they're a massive network, and they already communicate with, exchange data with, have consent with, do all of that with this massive number of service providers. So all of that work is already done, at least within our network and within aging services. Now, I can't speak for pregnant mothers. I can't speak for other what I would call human profiles that need to be served. I think our network probably is more organized, thank you to the Older Americans Act in Congress, and more standardized and sophisticated than a lot of other entities. And we have the benefit of, but quite frankly, for plans and others, the complication of the congressional mandate, because our systems aren't just going to go away. Those requirements don't just disappear suddenly because a CIE is formed or an MCO decides they want it done a different way.
No, that's helpful.
So you have to figure out how to layer it on top.
No, that's really helpful context, Courtney. I know we're a couple minutes over. Daniel, is it okay if we kind of take any kind of closing thoughts? And
yeah. There's a sort of a soft edge here, so we can go for a little bit longer. I know some people have to jump, but that's fine. But it's a engaging conversation, and
we often
don't
go
wanna-
into overtime.
double overtime. We're in double overtime. We don't always get there, but usually we get there.
Excellent. I am looking at the chat too. I think we'll definitely, examine other states 1115 waivers and Minnesota as well. I know North Carolina is another one that's come up in conversation too. Karen, are any questions coming to mind for you at all?
No, it's just really helpful to hear, from folks who are really in the CBOs and trying to figure out the different systems. I sort of hadn't thought about that piece of it, and so appreciated that perspective, and even more complex than I realized. So hope that we can continue to hear from folks on this call as we go forward. And
so, Robbie, where does this go? Where do you and Karen take this work? Where does it apply? What is going to apply to?
That's a great question. So we've done a lit review and all the desk research. We're just rounding out interviews. So, we've been talking with health plans, providers, some CBOs, technology companies too. We'll be drafting the white paper and are looking to have it finished by November at the latest, just to be able to kind of iterate and go through the rounds of review. And then Karen's also assisting with a 3-part event series in the fall, focused on the issue as well, around different, specific topics. So those events will take place this fall too. But yeah, we're aiming to have the white paper completed this fall, and I think have really specific recommendations for how health plans can be involved in this work. I think so far in our interviews, I think, a lot of what we've heard is that health plans really have a role to kind of support, but maybe not always lead on this work. And I think listen to CBO voices in particular and direct service providers when it comes to what the particular needs are on the ground. And I think a lot of the topics that came up around, specifically around funding, kind of right sizing technology too, those have come up in our other conversations as well.
Well, and Robbie, one of the other things I'll throw out, it does not surprise me or folks in our network that MCOs kind of gravitated towards the sharps, because it makes their world much easier. For them to try and hold contracts with hundreds of CBOs is really difficult. The problem is, at what point does you need to make sure that the care can lead and the technology supports it rather than the technology inhibiting it? And I think that's one of the concerns with some of these technology resources is it limits the amount of assessment. It decides that, okay, there's Courtney Baldridge. We've decided she has an issue with nutrition. We're going to give her a meal. Well, our experience over 57 years is if an older adult has a nutrition issue and needs a meal, chances are really, really good that they have other things going on as well that need to be assessed.
Yeah.
So again, it's not allowing technology to run the care. It's let care run the care and technology support it. And a friend of mine who's sitting here, Matt Bishop, said something that just resonated with me. And he said, technology should be like the lights. It's always on in the background working so that we can see what we're doing and move forward with our lives. So I think I really liked that analogy, that the technology is always there and should support what we do.
And you don't have to think about the light either. It just helps us communicate and deliver care.
It works. It works.
Whereas Facebook and Twitter, it's all about time on site. How do we get them using the technology more, as opposed to taking away, which is like the opposite. Doctors want to get away from their EHRs, right? So.
No, totally. That's really helpful. I think I was thinking of portal fatigue earlier, right? Which I think a lot of us have just in daily life, but I think that even probably gets amplified when you have, like in California, multiple managed care plans in a single county who may all be asking CBOs to use their own portal, and they're not coordinating on that. So it could be, triply redundant, I guess,
Well, and Robbie, it's worse than that. There's a tremendous AAA I'm thinking of. They input into 15 different portals. And in many of those, the MCO will not give them data back. So they're having to double keystroke. So, we're talking kind of what I would call equity in data for the CBOs. That becomes difficult.
Yeah.
That becomes really difficult. The other thing, there's a lot of issues that the CBOs should have a stake in. And I think if we don't embed the CBO voice, we're ultimately going to be tripped up by. And I'll go to, is Jim St. Clair still on phone? Yeah. One of your and Daniel's favorite things, consent. I tend to think that social care providers are better at getting consent out of patients and clients than medical providers. We do really, really well with compromised at-risk populations who have trust issues. So I think consent is a huge issue. I think endpoints, I know there are people who believe that the computer programming may be the endpoint, the sharp may be the endpoint, where we would say, it's probably the case manager and the service that was lost in their home that's the best endpoint. So making sure we capture that. Data ownership. Somebody said to me on the phone 48 hours ago, the person who has the data owns the data. And I was like, well, wait a minute, how'd you get the data? I mean, if you walk in my house and steal my diamond, you have it. That doesn't mean you own it. Yes. So, in this land of data sharing, who's entitled to what and how does that happen? Especially when everyone is asking CBOs for their data for free, everyone, that becomes a real issue. And so I think, there are some hurdles there that really need to be looked at. And I can't say enough about assessment and referral.
Yeah.
We know there are a lot of entities that are trying to move into the referral space. And then when they do the referral, they think it's, again, good enough just to get a little bit of information and make one referral rather than, to look at the broader care plan and refer to someone who's an expert in that area.
I'd add one quick thing, Courtney, because it spurred my memory too. I'm not trying to be disparaging of MCOs, but in listening to that in the context of it and what you get from an MCO, I've had firsthand experience with New Jersey's MCO, and I'll just lay this out there. The support contractor they hired used teams from their tax and accounting office to staff the MCO, not their healthcare business unit, which means you had a group of support contractors that weren't familiar with healthcare at all, anything about it. So the contextual sensitivity, a lot of what Courtney just brought up, as well as just what they're supposed to do as MCOs, may be lost on the person at the other end of the phone. So that may be worth considering too.
I couldn't agree with you more. And Jim, I'm seeing your note about the 49 out of 50 states say that the EHR owner owns the data. Now, keep in mind, in Older Americans Act, none of that data is shared with anyone else except for up to our funding stream. And I think that's true of many federally funded programs. Yet the MCOs and others, these are programs that have eligibility requirements, but they may have members who are eligible. They want to refer into these programs. It becomes a dicey situation. That data goes with that program. And in some cases, a state may say, that's our aging program that we have funded through our state unit, even though it's attached to the Older Americans Act, we have that data. ACL at the federal level holds the data. The AAA has that data. And then certainly that service provider has their own data. None of that is currently shared on an EHR level. So you're talking massive disconnects in terms of data that is never going to pop up to a HIN level or never going to pop up to an MCO level right now because of the silos. And I think there's some real issues to work through in terms of helping increase that flow of data and figuring out who has rights to what and what it looks like. Keep in mind, the other thing that's interesting is that our agencies all organize around AIRS, which is based off of LA 211 for taxonomy purposes, INR taxonomy. None of them organize around that for data reporting. And under Older Americans Act, the states can have different data sets. ACL has tried to do some alignment there, but there are differences, and that does not align with the Gravity Project data standards. So unfortunately, we are a very complicated space and a reality, given that we were mandated by Congress. It's not like anybody can just flip a switch and change it all.
No, that's helpful. And that's probably, I mean, I can imagine it's a similar situation for many other types of social care and different programs too. Oop, Daniel, I think you're muted.
Yeah, that's why I think it's also important to think about the flow of data the other direction, right?
Yeah.
So,
well, and it sounds like there's a need to really place an emphasis on, if you're collecting data, what is the value that you're providing to the organization as well as the patient from whom, you know, you're taking it, what are you providing back, whether it's data or something else, right? Like a net benefit to the CBO and to the patient as well.
Well, and Robbie, I'm seeing Shelley's note here that the patients must own the data and provide consent to share it. Much like the healthcare world, at least in our network, they have to, a client has to provide consent to share that data, as well as to share it with a family member or others. So, you know, I will say most states, maybe not all, but there are good consent rules in place for, at least I was on the phone today with some agencies about this very issue.
but Courtney, are those still mostly analog or digital? Computable consent or?
The particular agencies I was talking to today are definitely digital. Absolutely, there are going to be agencies where it is
paper,
hopefully not analog, but God only knows. And I will tell you, I mean, when you're dealing with the audiences we are, which are older, at risk, some of them have no caregiver. And I'll use my mother as example. I have an 84-year-old father who is happy to do everything on the computer, and he does. He's like a 14-year-old on his phone. I have a mother who's 82 who actually is having surgery tomorrow. So I've spent the whole week going through everything. And she wants them to call her and walk her through everything. And she wants to be able to sign her waiver. Now, I could help her do it digitally. She doesn't want to do it that way. And one of our agencies said to me today is that absolutely we can do it all digitally, but we have to meet the clients where they are. So they have to be prepared to do both.
So I want to draw a very clear, very important distinction between HIPAA saying you have a right as a patient to access a copy of your own information. 21st Century Cures Act saying, yes, you have a right to access that in an app of your choice. And the distinction between that and actually, and also HIPAA around, you know, you need to provide consent under certain circumstances that aren't treatment, payment, and operations. and ownership of your data. That's a wholly different issue together.
Yeah, that's exactly right. Mike.
Not like ownership. No patient owns their data in the entire United States of America, right?
Live free or die, New Hampshire.
Right? You can't control that I think is one of the biggest barriers to a consent decision service, right? Because if there was a law that said patients, not just that you have consent to be able to share it, but in order for other organizations to use your information, they needed your permission, right? That and there are efforts underway to pass state laws to be, you know, the first state for that to be a human right. But it's not. There's a big distinction of having a copy versus really controlling the entire.
Yeah, even under GDPR, the regulations vary from country to country, and there's an even more traditional non-Cures Act view in Europe. In certain countries, you're granted access to see your record as if, you know, it's a privilege to be able to see it, but it's still not owned by you.
And when it's de-identified, then anything can happen with it.
It's out of your hands. Yep.
It seems to like there's a need to. Is it data stewardship, right? Like, you know, regardless, I guess, of who legally owns it, that, you know, there's a need to be a good steward of that data in terms of what it's being used for and the value whatever use is providing value to the individual, you know, to whom it pertains. And, you know, maybe there's a way to also draw, you know, a connection to like standards and healthcare, like minimum necessary, right? Where, you know, in many instances, we say you can only share the minimum necessary to you know, get your job done. That, you know, there's a need for safeguards and guardrails when sharing data.
There's with TEFCA, like there is going to be like, you know, there is going to be a move. There's going to be a need for much more complex consent decision service like things to be in place. So I'm not trying to downplay it, but especially like as you're going across state borders and, you know, you have varying laws, and, you know, as Dr. McCoy likes to remind us, you know, one-way referrals from clinical to social care does not equal whole patient care or addressing fully the social determinants of health. So I think there is a need to, like, it's absolutely needed to have, you know, a way to control consent. I think COVID has shown just with like kids that catch COVID and their schools need to know immediately, right? Like that alone as a use case is an example of just one of many use cases where the direction has to go both ways, right?
Yeah.
Well, it does have to go both ways. And but I will caution you, I think you are going to see that social care does a better job of capturing consent for social care, and that there is going to be some decision points that are going to have to be built into the digital process for someone to say, nope, I want to hold these pieces private, and nope, I'm willing to share this with my social care provider because they come into my house every day and see how dirty my dishes are, but I really don't want my doctor to know that. Keep in mind, we operate in a much more intimate setting. And what we see oftentimes is clients are not really good with self-report. That's why assessments that are in the home are so much more successful than 12 questions on an automated platform. And there are certain things that they will not want to share. So I think building into consent flexibility to allow that client to decide how much information they're going to share rather than just totally shutting down on consent is going to be really important for all of us to think about. The other thing is you have to know consent becomes an equity issue, because if you look at who doesn't trust healthcare providers, it is typically diverse populations. And those who, English as a second language, who have low health IQ. And those tend to be the more diverse populations. So very quickly, consent becomes an equity issue.
And people with sensitive health information, like health conditions, where additional consents are necessary. I think that, the very clear, obvious example is just integrated behavioral and substance use care. Even if you're staying within the clinical area, cracking that nut around consent, it seems like even that's just all within healthcare, right? But it's not been solved from an HIE perspective for the most part.
Yeah.
Maybe somebody who works at an HIE is gonna correct me here, but.
Well, and as a population health issue where you don't really need to know that much about the individual, you need population health data and being able to offer consent. I think I threw in the chat the example, the HIV surveillance problems that were written up last week, where people don't have consent mechanisms and as such don't know why are you asking me this and what are you going to do with it for surveillance reporting purposes for critical population health issues where it really can be de-identified or consent can be given, but you need to know what's going on in population in Hep C or HIV or monkeypox through sexual transmission or whatever.
Okay, we're getting remarkably close to triple overtime, which I think we'll avoid this week.
Come on, coward.
No, this has been great. I mean, thank you all so much for all of these insights. I think that I think we have our recommendations, Karen. No, but I think what we could, I think what we can make sure to do is, share these findings back with you all, as we kind of round out our interviews with folks over the next few weeks. I think just thank you for all of the insights. I've got 3 pages of notes, and I think my colleague Sarah probably has several pages as well. So lots to kind of sift through. And I think if it's okay, we'd love to, follow up with some of you if we have additional questions, or if any resources or people come to mind that you think we should connect with for this project, we would, love those ideas as well.
Robbie, I definitely want to make sure that the AAAs out in California are connected. I know that they are aware of you all because I've talked to them about it. So I'm happy to help make that connection.
Yes, and I need to follow up with you separately for another related project, Courtney. So I'll shoot you an email after this meeting.
Please do.
Awesome.
Thank you, everybody.
Yeah,
Appreciate
thank you
your
so
time.
much.
Okay, so actually, we've got schedules for next 2 weeks. I think Greg Bloom is going to join us next week, talk a little bit about AIRS technology and some of the work that they're doing there with SDOH and other areas. And then Courtney, I think if you're still available, we've got you the week after that to dive more into some of these conversations. It'd be good. Let's see, that'll be
the 10th.
Yeah, the 10th, right. So that'll be the week before the ONC our workshop there, which will be great. We'll be over the next couple of weeks busy with that. So if you, I'm assuming if you're going, you're registered. If not, go ahead and register for it, and we'll send out some more stuff around that as we get closer to it. And hope to see everybody next week and on that session there as well. And we'll keep you posted. That's it. Have a great day, everybody. Thanks.
Thanks,
Ciao.
everyone.
Thanks, everybody.